Hi, welcome everybody for joining us. Thanks for joining us for our first webinar of 2025. So we're delighted to bring this webinar to you on behalf of the Global Tracheostomy Collaborative. I'm Amy Freeman-Sanderson, and I'm delighted to be joined by my co-moderator, Dr. Michael Branham. So our topic today is one that's been requested by many of our members, and we're listening and delighted to present to you today, anticipating, mitigating, and managing tracheostomy emergencies. So I'd like to just take the opportunity to also thank our sponsors for their unrestricted educational grants. This really supports the mission and vision of the GTC of creating multidisciplinary teams of physicians, nurses, respiratory therapists, speech therapists, patients and families working together to bring to you and disseminate best practices and improve outcomes around tracheostomy care. I'd like to acknowledge the land I'm on. So I'm in Gadigal country, so I would like to pay my respects and I welcome you today to wherever you are and pay my acknowledgement to the traditional custodians of knowledge for this land. So please feel free to pop in the chat where you're joining us from today. We love hearing where you're joining us from. So today we're in our hour of our webinar, we're going through a few objectives, and these are our key ones. So we're aiming to understand and anticipate tracheostomy emergencies in adult and paediatric populations. We're discussing systems and readiness and collaborative pathways, so really amongst all team members about how we diagnose, anticipate and respond to tracheostomy emergencies, and looking at how we engage stakeholders and leverage technology and opportunities to improve our emergency readiness. We have a fantastic panel. We're very delighted to have such an esteemed and expert panel joining us today. So I'm going to hand over to Dr. Michael Brenner to do the first introductions. So we'll introduce all the panel before we launch into the topic.
Well, it's a delight to welcome you all to this webinar, and thanks for that wonderful framing of this session, Amy. So the first of our speakers, I'm very excited to introduce. This is Ryan. Ryan Jolly is the mother to 4 children with brain injuries, including a 13-year-old daughter that has been trach dependent since age 19 months, and a 7-year-old with declining respiratory drive that is on a path that will lead to a trach or ventilatory support. She is a psychiatric mental health nurse practitioner in private practice and focused on families affected by fetal alcohol spectrum disorders and children with medical complexity. Ryan works with the Children's Mercy Hospital in Kansas City in a number of roles, including contract researcher, chair of the Parent Family Advisory Council for the Beacon Clinic, which is their complex care clinic. She's a member of the Tracheostomy Parent Family Advisory Council, Family as Faculty program, and in panel discussions with new staff as part of their mentor and training programs. In her private practice, she presents regularly to families, politicians, and professionals on the topic of fetal alcohol spectrum disorders. She's currently enrolled in the Doctor of Nursing Practice program and conducting research on efforts to reduce workplace violence in healthcare settings. From experience, Ryan is aware of the unique burdens that caring for a family member with medical complexity can place on the family, and she's passionate about advocating for better understanding and care for these families. The second speaker who I'd like to introduce is Professor Brendan McGrath. So he's one of the charter members of the Global Tracheostomy Collaborative and has led the largest guided implementation project in the world. To trace some of his background, Professor McGrath qualified in the University of Sheffield and trained initially in general medicine in Yorkshire, the Northeast, and then Australia. He returned to specialize in anesthesia and intensive care medicine, appointed as consultant at Manchester University NHS Foundation Trust at Wythenshawe Hospital in 2009. He was then appointed Manchester Academic Health Sciences Centre Honorary Professor in 2022. His research interests have focused on patient safety and airway management, which led to the initiation of the UK National Tracheostomy Safety Project which is widely used and accessed around the world. He's collaborated widely in developing educational resources to guide multidisciplinary response to airway emergencies. And realizing the real-world work was in prevention of airway emergencies, he helped develop the Global Tracheostomy Collaborative back starting in 2012, bringing together international expertise from Harvard to Melbourne, leading national events and international events in London, including having Stephen Hawking as one of our guests many years back, and has been essential for the goal of improving tracheostomy care everywhere through quality improvement initiatives. Dr. McGrath has worked on many domestic and international quality improvement projects and research studies, more than I can count in publications and considerable grant funding. And then the final person who I'll be introducing is my dear friend and colleague, Dr. Vincia Pandian, who is professor of nursing and recently ascended to the role of president of the Global Tracheostomy Collaborative. She's been an active member of the GTC since 2014, so this marks just over a decade. She is editor for our journal, Tracheostomy Journal, as well as the Journal of Clinical Nursing and Otorhinolaryngology Head Neck Nursing. She is Associate Dean of Graduate Education at Penn State, and her research focusing on identifying signs and symptoms of laryngeal injury post-extubation in the intensive care unit, as well as extensive work in tracheostomy with her work funded through the National Institute of Nursing Research. She founded the Center for Immersive Learning and Digital Innovation, where she established the infrastructure necessary to develop a multi-user virtual experience. She is a fellow of the American Academy of Nursing, the American Association of Nurse Practitioners, and Critical Care Medicine. She's held a wide range of leadership roles, and she is the recipient of a Lifetime Achievement Award in recognition of her lifelong commitment to building a stronger nation through volunteer service, which was awarded by the AmeriCorps and the Office of the President of the United States. It's a pleasure to have all of you presenting at our session. And now I'll hand things back over for introduction of our remaining three speakers. Thanks, Amy.
Thanks, Michael. So our other three panelists, so I'd like to introduce Associate Professor Stephen Murillo. So Stephen is an intensive care physician and the Director of the Department of Intensive Care at Austin Health in Melbourne, Australia, where he's also the Divisional Director of Medical Services. His private practice is based at Epworth Healthcare, where he is the Director of the Critical Care Institute. So in addition to his clinical and admin responsibilities, he has an academic appointment with the University of Melbourne, and he is a past examiner with the College of Intensive Care Medicine and a current senior examiner for the Royal Australian College of Physicians, as well as the past president of the Australian and New Zealand Intensive Care Society. But during the COVID response in 2020, he became the lead of the critical care response for the North East Cluster and chaired the Victorian State ICU Directors Forum. He was lead author on the ANZIG's 2020 Pandemic Ethics Guidelines, and for over 10 years, he's contributed to the Global Tracheostomy Collaborative to promote improvements in MDT care for tracheostomy patients. So his previous roles have included working in aeromedical retrieval, perioperative medicine, general medicine, organ donation, medical specialist, KICM supervisor of training, RACP supervisor of training, and chairing both state and national committees for KICM, the RACP, and ANZIG. In 2019, he convened the World Congress of Intensive Care when it was hosted in Melbourne, Australia. And his professional interests include critical care outcomes, clinical governance around these, end-of-life care, clinical teaching, and complex communication. So his main research interests centre on critical care hepatology, and he completed his PhD with the University of Melbourne as a part of his ongoing research into the management of acute liver failure. So with over 100 publications in the field, he's contributed widely to advancing critical care. So outside of medicine, in his alternate hours, he has lots of other hobbies. So welcome, Stephen. I'd like to introduce Ricky L. Williams. So Ricky is the clinical manager at MedStar Georgetown University Hospital in Washington, DC. So he's now in year 28 as a respiratory care practitioner and has a wealth of experience in almost 3 decades of practice. So his master's is in healthcare management from the American Intercontinental University. He served as a champion of the hospital's multidisciplinary airway team that focuses on providing best practices in managing patients with tracheostomies. Ricky has previously worked as a director of cardiopulmonary respiratory therapy in an LTAC in Washington, D.C., where he started up the ventilator unit to 26 beds. Other experiences, he was placed in charge to open a pulmonary care progressive ventilator unit for long-term skills in a long-term skilled nursing facility with 36 beds. In both facilities, he was instrumental in starting the tracheostomy airways team that was successful in tracheostomy management and importantly led to reducing adverse events and also improving decannulation. His vision and mission of the airway team is to maximize airway communication, so specifically use of one-way speaking valves, looking at capping and decannulation to all candidates that meet the criteria, education as well, and consistently providing evidence-based research to the team and including patients. So rounding out this stellar panel, I would like to introduce Dr. Christina Yang. So Christina Yang is the director of the Pediatric Aerodigestive Program and Pediatric Otolaryngology Quality Assurance at Montefiore Medical Center. She's also an associate professor of otorhinolaryngology, head and neck surgery, and pediatrics at the Albert Einstein College of Medicine. Dr. Yang received her MD at Northwestern University Feinberg School of Medicine, Honours Program in Medical Education, and completed her residency in otolaryngology, head and neck at Tulane University and a fellowship in pediatric otolaryngology at Cincinnati Children's Hospital Medical Center. Dr. Yang also has completed a Master of Science in Clinical Research Methods at Einstein in 2023. Her academic interests include the integration of healthcare SIN, implementation science, and human factors to improve safety and quality for patients. So thank you everyone for joining us. As you can see, we have quite a wealth of panelists, so we're looking forward to going into our discussion. We also really welcome participation from our wider audience. We all learn from each other, so please feel free to add in chat. So thank you. I believe that is now enabled. So if you have a comment, you can add there. Alternatively, a question and answer that you would like posed to the panel, please enter that in the Q&A box. You should have those icons available to you down the bottom. So with that, let's kick into our discussion. So this webinar, we've got a couple of main topics that we would like to cover and invite the panel to lead us in discussion of. So the first is tracheostomy emergencies. So really defining what are they. So I'm going to have this slide up. We've got some visuals to help us. So I'll answer Michelle you in the chat in a moment. So looking at red flags, and I would like to first of all invite Professor Brendan McGrath to talk us through what are tracheostomy emergencies. We hear this term and it varies. So can you talk to us a little bit about this in your experience?
Yeah, sure. Thanks, Amy. So I guess the sharp end of trachea emergencies is where something goes wrong and the people at the bedside or in attendance need to do something to help the patient out. Sometimes the patients can help themselves, but quite a lot of time, depending on the dependency of the patient or the age of the patient, they need a little bit of help. And I guess emergencies cover a wide range of topics, from something that needs to be checked through right the way through to life support and sort of resuscitation and interventions that are required to sort of unblock the airway. What we'll try and talk about on this webinar are some of those sort of warning signs that occur that give you a clue that something's going to happen, because we started our sort of journey trying to understand tracheostomy problems in the UK by looking at emergencies and trying to identify common problems that we felt could be linked into themes, usually around equipment, training, and support of people attending emergencies. And if you work in a big hospital, around the infrastructure. But when you look at the incidents, there's often these warning signs that give you a clue that something is about to happen. And I think we've got a few slides coming up that highlight some of these problems. And if you have a tracheostomy problem brewing, because our patients have sometimes altered airways, or they're sometimes dependent on oxygen or on ventilators. If you have a problem with your airway, it can very rapidly develop into other problems that can become rapidly life-threatening and require that sort of more resuscitative intervention. I wonder if I could bring in Stephen just to perhaps talk a little bit more about how these red flags can develop into some of the problems.
Yeah, thanks, Brendan. I think we've often in the past spent a lot of time discussing the obvious crisis, and those matter a lot, and we should absolutely train for those, particularly in both the acute and the subacute or home setting. But I think many of us would reflect that the problems that we more often see with tracheostomy care is the slow burn. Is this a crisis or is this not a crisis? And the benefit of hindsight has taught us much. And I've often shared with my junior colleagues, it's better that you learn from my mistakes rather than having to learn from your own. And I think it's a good opportunity to discuss some of those things which are the evolving issue, the suction catheter that's not quite going down so easily, the quote unquote cuff leak that just goes away temporarily with more air in the cuff, but then recurs. And also, if I'm talking about a cuff leak and the nurse is talking about a cuff leak, are we talking about the same thing or are we talking about two different things? So I think many times when we review adverse events, the signs were in retrospect there, if only we'd had the wherewithal to take note and act accordingly. And I've certainly developed the mantra for myself, never let the sun set on a tracheostomy problem. Sort it out before nightfall, wherever possible.
I could see a lot of nodding heads with both of your comments, Brendan and Stephen, just in terms of looking at how we define emergencies, how that might present differently across different members of the healthcare team. And so, in terms of that, Brendan, you also flagged that we can have, I guess, categorize emergencies in different ways in terms of they may be across, various aspects. So some of these aspects or flags that both of you mentioned can be under airways, breathing, and we'll go through that. But I was keen to just hear from any other panelists in terms of emergencies, and we'll come from, defining emergencies as well in terms of, maybe Ryan, if I could ask you as a parent in terms of emergencies and what that means to you in terms of the definition.
Well, I like the comment about not letting the sun set on your trach emergency. In our family experience, the trach emergency never happens on the day when you're well rested and well fed and in possession of all your faculties. It's days when you're exhausted and it's 3 o'clock in the morning and the alarms are going off and you're bolting upright in bed. So I think we'll talk on it a little bit later, but anticipating what could happen, knowing those warning signs and paying close attention to them helps us manage those acute needs better in our home.
And I mean, that might be a nice segue because we're looking at emergencies. Tracheostomy emergencies can vary and they occur across a continuum. So we're going to get to, and I want to drill down into detecting emergencies a little bit later, but in terms of this anticipation and recognition of emergency, a couple of scenarios have already been raised by the panel, and I've got one here to sort of pose to the panel and centre our thoughts in terms of, could this be an emergency? And we might break it down into the areas. So we've got can't suction that been mentioned. So this is a fictitious case, but one that I'm sure many people on the panel and the audience will resonate with as well. So Sarah's currently experiencing difficulty during suctioning. So the healthcare provider has noticed that despite multiple attempts, suctioning is not as effective in clearing her airway as it normally is. her oxygen saturation levels have been fluctuating, and she's actually becoming increasingly anxious just due to the discomfort and the perceived ineffectiveness of suctioning. So let's talk about this in terms of anticipating emergencies, so those that have presented themselves or not. So in terms of panelists, I know, would somebody like to comment first on this? So maybe we can go to Brendan and Vincia. Is that okay?
Yeah, sure. So why don't I kick off, Vinci? I mean, as Stephen outlined, there's a couple of classics that we see, certainly in my world in intensive care, where you'll hear a report that the suction catheter won't pass. And sometimes, as Stephen's alluded to, perhaps people who are less experienced with tracheostomy care might go, oh, well, couldn't get the suction catheter in. Whereas anyone who's sort of been in those situations before, usually your ears prick up at that point and you'd be like, oh, okay, why is that then? How's the patient? And this is one of those situations where you should be worried about it. It might be nothing, but it might be something. And as you said before, when you look backwards from those emergency cases, there usually is a little clue that something wasn't quite right. So, for example, the suction catheter not being able to pass. And I think in that situation, the action that we advocate is that the patient needs to be assessed, or the person needs to be assessed by someone who knows what they're doing. I don't know if I can bring you in there, Vincia, to talk a little bit more about that.
That sounds good. Thank you, Brendan. I agree with you. I think we do need to assess the airway, but one important message that I would like to share to whoever is responding to the situation at first, in this situation, it's the nurse. The key is to stay calm and assess the patient, because often along with the patient, the provider also gets anxious, and that kind of gets things out of control. One of the things that I educate my nurses is to request them to remove the inner cannula and see if that helps. And the other thing you also want to think about is whether that trach tube is the right size, and not the trach tube, the suction catheter that the nurse is using, is that the right size? And then also check if the tube is dislodged or kinked, or whether it's blocked. And if so, then you may want to be thinking about an emergent tracheostomy tube change. In terms of assessment, you definitely are worried about the oxygen saturation, which is fluctuating, which is helpful that it's going up and down, but it could decline pretty rapidly. So we need to respond quicker.
And I mean, you both really sort of mentioned that need for assessment and that the situation can change. And that really highlights that the situation for the patient, how the health care team needs to respond, can vary as well. So it's that sort of constant awareness. I can see people raising their hand as well. So what I'll do is just direct you to put any comment in the Q&A if that's okay, and then I can we can keep an eye and make sure that your comments are added into the panel. So thank you everyone for your engagement.
If I can add,
yeah.
I often think of it, once this has been raised with me, certainly in ICU, I don't get to walk away until I've proven that the tube is not occluded and that I've proven that the tube is correctly positioned. And if I can prove those things, then I get to relax a bit and think, you know, but I don't get to walk away until I've proven to my satisfaction that those two conditions are met. It shouldn't. I have to prove that those things are okay. The patient shouldn't have to prove to me that they're unwell, if that makes sense.
And I have an additional comment. I think piggybacking off of what Vincia was saying is that quite often there will be at least one member of the team who has an idea or a model of what is going on, but sometimes the team is not sharing that mental model. And so I think it's very important to actually say out loud, the suction is not passing. I think it might be out. I think it might be occluded. Let's go through these steps and figure out what's going on so that everyone is on that same page, and that one person who's trying to both assess and perform tasks doesn't feel alone. There might be 6 people there, but if only one person has the idea of what the next step might be, then probably won't be successful and efficient in getting to what Stephen was saying, of being able to walk away confident that the tube is patent and in place.
If I may add to that, in addition to that, what we want to prevent is sub-Q emphysema, because something as simple as not passing the suction catheter through the trach, what you want to do, as Dr. Vinicia said, you want to remove the intercannula, inspect. And if you're not able to, from my experience, then you may want to move forward, increasing the oxygen, and then move forward quickly to changing the trach to. It's pretty much like stopping the train. You come to a stop sign, you're not able to go through. You have to do maneuvers, wait for the green light, and that's adding oxygen, being able to suction, and changing the trach. One thing we don't want the patient to do is to begin to de-escalate. So the key in this example is the difficulty doing the suction procedures. And also, as Dr. Vinicia said, a calm team.
I would add to this case study or the scenario, let's not forget the patient in the efforts to solve the problem. That says that Sarah here is getting anxious. She's aware that she's in distress, and probably a couple dozen people came running into the room to try and help solve this problem. A calm word, a reassuring handhold from some member of the team for the patient that you're working on it and it will be okay, makes all the difference for both the patient and the family at bedside.
Yeah, so all those elements of seeing what is needed, keeping calm is everyone sort of talked about that, and the strategies to do that. So multiple strategies in terms of acknowledging those feelings of anxiety. I'm here to help as a team. As Chris said, talking aloud as well, and sharing shared mental model, and also those concepts of determining what the emergency is, but also what the emergency is not. So looking at both of those elements of how we might think about different emergencies. So I've just got a couple of slides here and we can move through them quickly, but it was just separated into those areas that we highlighted before. So in terms of, yeah, go ahead, Michael.
Before you move to those additional slides, I'll just for a moment take off my cap as co-moderator and just add a comment from my perspective as a otolaryngologist, head and neck surgeon. So if you go back to that vignette, one of the interesting things that it states, I don't have it right in front of me, but it says that the patient has anxiety due to the discomfort from the suctioning and some other, so due to the discomfort and perceived ineffectiveness of suctioning. But we don't really know why our patients are anxious. We might be able to perceive it, and it's well documented that patients that are deemed to be anxious often really have an issue that stems from hypoxia and an impending airway crisis. So a patient's anxiety, particularly in an individual with a tracheostomy or any complex airway, should never be taken lightly. We also see this in individuals with laryngotracheal stenosis and any number of impending areas. So this really speaks to the point that Dr. Warlow had made about the importance of an anticipatory approach, and what Ryan had said about not letting the sun set on a potential problem just around the corner.
It also helps to have the emergency equipment in the room instead of having to run out to get it. That just add additional anxiety to it. So just being prepared for the unforeseen makes the situation a lot smoother.
Yeah, and with a comment in the chat from one of the attendees, Nicole Jenkins, just also letting the patient and the family know about some of those discussions that are happening, and some of that is the team working through those possibilities. So really stating some, what those discussions are about as well, for that clear communication across everyone. And we've got the comment, no such thing as being over-prepared. So definitely. So moving through these and just sort of highlighting them, and the slides will be available on the recording as well to go back to, but just highlighting some of the information here. that has been put together. So looking at airway flags and some examples there. If any panelists want to jump in and add any information, please feel free as well. So we've got the breathing flag as well. So separating that from the airway, but obviously both are connected. So particularly looking at around breathing patterns, but also supports around ventilation requirements as well. We have some specific tracheostomy flags. So we had mentioned of the displaced tracheostomy tube. So displacement can be, I guess, various aspects as well. So maybe a panel from the comment from the panel about that in terms of displacement. So we could have ultimate removal and sort of slight displacement as well. So any comment on that in terms of different tracheostomy tubes? So we've got mention of an adjustable flange tube. So what's the important part there to consider?
Yeah, perhaps I could come in on that, Amy.
Yeah.
So displaced tracheostomy tubes are probably the most common problem that we see, certainly in the intensive care population and people who are attached to ventilators who have got a lot of tubing, and when you get mobilized, you know that there's risks of pulling things out. So yeah, displaced tubes are a potential problem. The problem with displaced tubes is it's not always obvious what's going on, because a displaced tube can look absolutely fine from the outside, or a patient can have it in their hand. So there's a whole range of scenarios that you may find yourself in. And as we've sort of alluded to with some of the comments from the other panelists, you know, sometimes the patient knows that there's something not quite right. So if it's a parent or a carer or the patient themselves just telling you that something's not quite right with a tracheostomy tube, it may have moved quite subtly. The thing with adjustable flange tubes is we often use them in big adults, and adjustable flange tubes can move, and that comes down to your sort of record keeping and knowing where the tip of the tube is, because again, you can have a tube that looks fine on the outside but isn't in the right place on the inside. So those specific tracheostomy flags are the sort of things that are airway problems, but they're specific to the bits of plastic in the neck.
Yeah. Also, if I may add, when the patient's on the mechanical ventilator, what's called your peak inspiratory pressures may either elevate or they may be low. For example, if the cuff is blown, and what we use is a cuffulator, when we go to inflate or put air back in the cuff and it consistently escapes, then we know the cuff is ruptured. Or if there's the peak inspiratory pressure can identify if the cuff or the trach has shifted, and just following up with suctioning and those maneuvers can also identify red flags with the trach.
I'll pitch in as well. I think in an obese patient in particular, it's there's a fair bit of movement that can occur with a tracheostomy tube prior to it landing in the patient's lap. So I've had many clinical colleagues seduced by the notion that the tube looked okay from the outside. It may not be in the airway anymore. And another pointer I often share, as I put in the comments, is if we're waiting for hypoxia to become apparent as an indication of airway compromise, that's pretty late. Patients are a fair way down the path of disaster if we're waiting for them to desaturate, and early signs are the catheter is not passing so easily, the patient's anxious and expressing concern that their breathing doesn't feel right, the high pressure alarm on the ventilator, as Ricky's indicated, that those things not always so obvious, but when you look back and review an adverse event, are often present, and also the leak, which I think we're going to come to shortly.
Thank you. And outside of the tracheostomy tube as well, we need to step back and really, this has been highlighted by some information that Brendan provided for this. So it's really looking at sort of, you know, those wider physiological changes as well. So looking at how the emergency evolves. So in terms of, we've talked a bit about what emergencies are, that they occur in different across different categories. So we might have one category, or it might be happening across a few. So I want to drill down and use your expertise in regards to how do we use algorithms, cognitive aids, and supports for managing these emergencies. So I will start with a little vignette. So perhaps this will start up some of the thinking. So this is blood and secretions, and one that can come up quite frequently. So Charlie's been stable on the ward. So in the setting, they happen to be in a care facility. But today, his secretions are noted to be tinged with blood. So he's having difficulty with suctioning, and there's concern that about the presence of blood, and this may indicate a complication. So his parents are concerned. So he's a child, and they've not seen this type of secretion before, and unsure whether this is actually expected or not. So, perhaps let's talk through using this scenario to how algorithms can be used, and I can advance through slides as needed.
I think before we talk about the algorithm, I want to take a moment to talk about what could be the potential causes for these blood-tinged secretions. One of the common reasons is the trauma from suctioning itself. When I went to nursing school way back when, they said, advance the suction catheter until you can't advance anymore, pull it back a little bit, and then suction. But you know how the right main bronchus is positioned. When you advance it, it actually ends up in the right main bronchus sometimes, or it's hitting the carina. And these can be very traumatic for the patients. There was a time when one of my patients continued to have these blood-tinged secretions, and I went to scope them, and it was like a polka dot design in their airway. With every suctioning, we were actually pulling a little bit of their mucosa out. So that's, I think, one of the most common reasons. The other is the airways being dry and just irritated with lack of humidification. So we may want to think about that, or infection in the area, or granulation tissue formation, sometimes ulceration or erosion from the tracheostomy tube itself, pressing against the tracheal wall. Of course, there are some rare causes I think we're going to be talking about that. Just wanted to set the stage for our conversation in terms of what could be causing these blood-tinged secretions.
As well as the patient may be on blood thinners or recent trach change. So we want to monitor that or find that information as well before we begin to, as you say, apply the algorithm.
Mm-hmm.
There's one other important thing in there, Amy, which just brings back to something that Ryan said about 10 minutes ago, that when we turn up to the room as sort of supposed airway experts, we're not experts in the care of that particular person often. And if there's family members or carers who know what normal and healthy looks like, and they know there's something not quite right, they're really important people to listen to. And sometimes, depending on where you are, they may actually be the practical experts in the room as well. And so I know we sometimes see carers and families come into hospitals, and they assume because they're in a hospital that everyone else knows better than them, but that's not often the case. So I think that's another really important message, just to sort of bring out that if somebody is telling you things aren't quite right, they're usually right.
I would add that as a nurse that's seen my share of traumas in rooms that look like a Tarantino film with blood everywhere, it's a completely different scenario when it's your loved one, when it's your family member that's coughing up blood. So in the home setting, determining what's a true emergency in a clinical definition of an emergency versus a change in your status that's scary can be a difficult thing to do. Adding on to the comments about the various things that can cause blood and bloody secretions in the trach. My daughter has a chromosomal abnormality that resulted in malformation of her airway. So when she has excessive coughing, the end of the trachea, or the tracheostomy, or the cannula rubs on her trach. So she causes her own bleeding from coughing when she's ill. Took us a while to figure out that that was the case. But now that we know, we go through a series of steps so that we can kind of mitigate our runs to the emergency room for something we have pinpointed a potential answer for.
I think one of the hardest things which I find at the bedside in ICU, and I imagine is very challenging for people in subacute or the home setting, is really trying to determine, is this a crisis or is this not a crisis? Because jumping at every shadow can end up being unhelpful. And yet none of us would ever want to miss a very serious Herald's bleed that is a prelude to, for example, a tracheoinnominate fistula or something of that dramatic nature, which are remarkably rare, but can be obviously catastrophic if missed and not acted upon in a timely manner. And I think that's often one of the hardest things, even often for experts, to try and anticipate, particularly when it's Friday evening at about 8:30 p.m. and you're handing over and suddenly the bedside nurse or a carer or someone will say, there's a streak of blood. What do you think? And I think sometimes I spend time thinking, well, I don't get to go home until I prove this is not a catastrophe. If it ends up just being some mucosal irritation from enthusiastic suctioning by someone less experienced, not ideal, but that's okay. We can sort that out conservatively. Or is the tracheostomy looking more pulsatile than it did before and other issues? And how am I going to find a way forward to determine things to ascertain what's going on here? How do I address it? And what's the pragmatic way forward?
One of the things you mentioned, Stephen, is quantifying the amount of blood. And from my experience, many times nurses at the bedside are the ones managing it, and they throw away the gauzes. And by the time the provider comes to the bedside, there's no sign of bleeding, and it's very hard to quantify. So if any of you are at the clinical bedside caring for patients with tracheostomy and you're concerned about the bleeding, I would recommend that you save the number of gauzes. It's easier to quantify to really figure out what's going on with that patient.
Yeah, our really savvy patients take pictures in the moment, and I think to the point of that the patients and families are often experts. We also try our best to create an infrastructure in which they can have a consistent person to talk to that also knows their patients and families well, so that they would know, oh, we saw you in clinic last week. We are your first point of contact. We're seeing you long term, and we know what this person's usual is. Because in the complex systems in which we work, if they're coming to the emergency room, meeting 6 new people, it's really hard to understand their baseline and not get lost in the shuffle of, again, is this truly an emergency? If they're being evaluated by an emergency department team that doesn't otherwise know them and doesn't know the context, or if they've had 3 phone calls before coming, they've been trying to manage this at home for 3 or 4 days before making the decision to come in. And so as much as we can try and provide that continuity of care between the inpatient, outpatient settings, and then in the critical transitions from pediatric to adult, we try to.
And I mean, reflecting on whatever you're saying, so it's the assessment is paramount. So it's assessing what is going on, having evidence. So in terms of what we're seeing, if we can, keep the gauzes as other sort of documentation of evidence, and sort of be able to assess and discuss and establish in terms of, is there something that I need to do further? Just some comments in the chat just around parents and families with experience, just mentioning that their own sort of ability to understand what is usual and what's happening for their family member takes time as well. So that's sort of something that evolves over time with individuals. And I think each person, some of these emergencies, yes, they go across individuals, but we have individual characteristics that are unique to that person. So looking at, listening to that person and what's happening to them. In terms of the slides and the time, I feel like we needed a part 2, but I will move through a couple of the slides and just highlight the algorithms, because I really want to get on to how do we implement them. But just to flag in terms of there are different algorithms that exist, and so looking at which ones sort of match with the bedside. So in terms of these particular algorithms, a lot of these are, so Brendan might be able to comment, so from the National Tracheostomy Safety Project, and there's
Yeah, sure. I mean,
other
why don't I
ones.
just talk through these very quickly, Amy? Because I think you're
Okay,
right. We need to
sure.
focus on a few other things. I mean,
Yeah.
you can find these links on the GTC website. If you type tracheostomy or tracheostomy, depending on which part of the world you're in, into Google, you'll find our website in the UK, which has got lots of videos about how to manage emergencies for adults and pediatrics. That these are meant to be one-stop shop algorithms that take you through the problems that are most common and are most easily fixed. And the lower down the page you get, the more trouble you're in, basically, and the more help that you need. You could probably just flick through these slides one at a time quickly, Amy, because they just assess, is the patient breathing? And it tells you what to do if the patient's not breathing. It tells you on the next slide where to stick oxygen if you know that the upper airway is patent or not, which will come from, your prior knowledge and from the carers and sometimes the patient. On the next slide, we talk through some of the simple things that some of our panelists have already highlighted. So if there's things on the end of the tracheostomy, they may be blocked or, with secretions or blood, so remove them. Removing inner cannula, which I think may be on the next slide. Simple things that we can do. And then the suction catheter is often your friend in these situations. It will help clear the problem, but it will also give you that assessment of whether the actual suction catheter can go all the way through the tube, all the way into the airway. Because a lot of our patients, when they become unwell, the tracheostomy is fine. And so sometimes part of that initial assessment is establishing that the trache's fine, it's something else. And I think perhaps on the next slide, we get to this decision point about working out whether our simple interventions to fix the problem have worked. If the patient's getting better, great. If they're not getting better, we need to empower our colleagues, our responders, to do something, which is often removing the tube and changing the tube or moving on to other sort of airway maneuvers, which will provide oxygen to the patient. And one important point just before we move on is it's all about getting oxygen in. You don't necessarily need to have a nice shiny tube in. It's just making sure the patient's got enough oxygen in. So that's a whistle-stop tour through managing a tracheostomy emergency, the principles. That there is plenty more resources that we can signpost to. But I think we should probably move on to your next section, and I'll let you take that away, Amy.
Thanks, Brendan. So in terms of a brief discussion around how to implement systems and training. So I really want to invite Chris to talk about this first in regards to all of your work around implementation and how do we make these practices stick, and how do we support families and also our workforce as well.
Sure. Next slide.
Yeah. So
Oh,
I might move to your next one.
Sure.
Yeah.
So, as we've kind of alluded to throughout these discussions, training is important, having skill carriers is important, but in real life, often we see some of the issues that come about are systems related. Even well-trained teams might not function perfectly depending on their environment and the degree of stress. And so we performed in situ simulations in the actual hospital environment, as have the Brendan's team and several others on this meeting. They're particularly well suited to recreate high acuity, low frequency events and assess how your team in real life to a mannequin, but in their usual environment with supplies as they would usually be located or not present, are on a daily basis. And so we've used it since 2016 at Montefiore. Next. With the same scenario every time, basically. We have a peds version and adult version where if they're on a vent, their desaturations, as well as the alarm with the peak pressures that Ricky alluded to. And if not, then just the desaturations, and watch the frontline team respond and troubleshoot. Next. We have a little vent alarm to recreate the realism and stress. And then we, after 5 minutes, see how they're doing with real-time assessment of the critical actions, and then debrief. Instead of having an open-ended, how did that go? We ask, how is your system functioning regarding the team How are they communicating? What are things that you notice as far as equipment availability and resources where you're working? Next up. And then this is the idea that the system in which we work is one of the inputs. So, if you're working in a place where the people and teams communicate well and the tools, technology, equipment is there, the tasks are clearly defined, you're well trained in them, not overly complicated to do basic things like getting a trach tube at bedside, and that the environment is performing well, that would support teams to respond effectively and consistently. Next. And so this is based upon the idea that we should be ready for all emergencies, similar to work with the National Pediatric Readiness Project that we're working to see, okay, well, is your system trach ready also? Next. And so we've been able to work with other otolaryngologists, pulmonologists, simulation experts, et cetera, just get that kind of idea. On the left, there's the steps you need to do, but on the right, some of the systems components that should be in place for us to be successful for both routine and emergency care. So everything is there and we can prevent emergencies, but also if these emergencies occur, that in 30 seconds, the ICU team can readily respond, or the floor team, the emergency department team. Yes, they can page ENT, but they're proud to say they've taken care of it by the time we've arrived. Next. And then, as I alluded to, we're able to actually assess this in real time, and so we can say, okay, well, 6 months ago they were responding in 3.5 minutes, and after various interventions, they're able to get it in 45 seconds and actually see some objective measures of performance. Next. Thanks.
Thanks, Chris. So, I mean, in all of that work, gave a couple of examples that other panelists can comment on as well, just in regards to SIM, looking at the systems and looking around at the supports as well, that sort of more widely support those systems. So there's multiple layers to that. And I was particularly interested, Ryan, in regards to, we talked about the other day about readiness and family readiness in the community and how you implement these algorithms or systems as well. So I wondered if you could comment a little bit about steps in your family implementation of what you do for your readiness.
We have certainly stolen completely the nursing process training and used many of the things that Christina just shared with us. We have routine bag checks to make sure her go bag has everything in it that we would need. We test the equipment, we test the chargers, all of those sorts of things. In the home health setting, I find myself in the role of trainer often when we have turnover in staff, that they have little to no training in actual, beyond the mannequin and their simulation and their nursing training, however far back that was, no real life experience in trach care. So we utilize all the things that have been discussed. We have signage in her room. We have things that speak directly to her care, and then some practical things like our physical address for our house is on a poster in her room, so that when the nurse needs to call 911, she's not scrambling trying to remember what our house address is. Practical things like that. Her safety plan is posted on the wall, the step-by-step implementation. So we've been very fortunate to be the beneficiaries of work from this group and others that have provided those materials that we modify for a home use, and that's really been helpful for us.
Yeah, and I was thinking about your comment about parking.
I'm sorry, about what?
About parking spaces.
Oh, so there's practical implications or implementation too. I said in our planning for this that the old military axiom that no battle plan survives first contact with the enemy, no plan for caring for an emergency for your child survives the actual event. So all the pre-planning that you can do is helpful for us. Like parking, when we go to the grocery store, we park in a handicap parking space, whether she's going inside with me or she's staying with someone else that's trained in the vehicle, so that if we need to call EMS, we know where to send them, not just to a general parking lot, find us. We're in space 3 in the emergency parking or in the wheelchair parking. So practical things like that have been helpful for us. If you don't have a backup plan for your backup plan, you don't have any plan at all kind of person. And so that kind of mentality has helped us.
Thanks, Ryan. And I mean, continuing our got a couple of minutes just for our last topic, and really wanted to circle back to Ricky and Vincia as well in terms of across the MDT, we all have different roles, and looking at this how to be proactive versus reactive, and just your thoughts and pearls of wisdom. So I'll hear from you first, but of course all the panelists can join in. So
Right.
Ricky.
Yeah, sure. I believe that with everything that we discussed today is extremely important. If your hospital doesn't have a multidisciplinary team, I would recommend that you establish one, just like we have this panel here today and share information worldwide. And it starts with education and knowing your patient. And as it was stated earlier, each patient is different, and the family members have so much information, a wealth of information to share. It's good for us to adopt that information, whether they come into the emergency room, find out what occurred in the last 24 hours. With our team, what we do is make sure that during schedule changes, we change trachs every 30 days so everyone can get their hands on what we call routine changes. So when that emergency event occurs, some of the anxiety is lower. Other maneuvers in being proactive versus reactive, advancing the patient. Are they able to use a Passimir valve? Are they able to advance to a cap? And just having that communication with them. And unfortunately, if they're a chronic trach patient, educating the patient on what to do, not to pull, simple things as not to pull on the neck band. That may shift the trach so that they can be safe. But again, you want to have like the signage, whether you're at home or in a hospital, to identify red flags and also know what's different with your patient. Something as simple as coughing when eating. Are they to use the speaking valve or not when eating? So education is primary. Identifying multidisciplinary team is monumental. And these are some of the methods that we can use in being proactive versus reactive.
Thank you, Ricky. To add to what you shared, many times when we're thinking about educating patients and family members and getting them ready, it always begins once we've deemed that they're ready to be discharged, or the conversation about discharge begins. From my perspective, that education needs to happen even before the tracheostomy is offered to them. So when we're having the discussion, do they need the tracheostomy or not, start the education at that time itself. And while the patients are in the hospital with a tracheostomy tube, educate at any opportunity that comes along the way. And from a multidisciplinary tracheostomy team standpoint, I love it when respiratory therapists, nurses, and speech-language pathologists partner together to take lead in certain aspects of the tracheostomy care. So that way, the patients and family members get different perspectives along with the physicians in terms of long-term care. So I agree with you that proactive is very important, and proactive is not when we think that the patient is ready for discharge, but from the time we're starting to talk about whether the patient needs a tracheostomy or not.
Thank you both. So it's really highlighting the importance of working as a team and clear communication. And Barb has sort of put in the chat as well. So looking at sometimes those are really limited and and time critical, and looking at what we do both at the time of emergency and also before and afterwards as well. So evaluating what went well and what didn't as well. Any other comments from the panelists before I just move forward?
I did want to make a comment based on one of the questions that were raised, whether these algorithms can be modified. And I've had to do that in one of our community hospitals because that particular hospital did not receive a tracheostomy on a regular basis. And when nurses encountered a patient and they pulled the algorithm, it seemed very complex for them. So we had to divide the algorithm into two pieces in terms of what the first responder as a nurse or respiratory therapist would need to do first, and then break it to the part once you call the code or once you've activated the experts, what would they do? And talking about these algorithms, you know, when we think of BLS and ACLS algorithms, it's mandatory for nurses and for everyone to take before they care for patients. But this has never been mandated. So I'm wondering if there is an opportunity for Global Tracheostomy Collaborative to partner with national organizations to really push this through, to add it to their repository. There was also a comment here asking whether this algorithm is applicable for patients and family members at home settings. So there is an opportunity for us to learn as well and probably create new pathways that are more patient-friendly, more community-friendly. So just wanted to share that.
Thank you, and I think you really highlight you know, an important aspect of where we need to sort of address and future work that we need to build on and work together. In terms of the time, I'm mindful that we've had such a rich discussion, and I feel that we could definitely have part 2 and even part 3. But I wanted to thank the panelists so much for your expertise, for your input. I think we really sort of across our discussions and key topics talked about what the emergencies are, types of emergencies, how you might detect them, and looking at tools and systems for also diagnosing, mitigating and responding. So this is our first of 4 webinars this year. So our next webinar will be in May, the 1st of May, 5 p.m. Eastern Standard Time. So again, you heard about the website. So there's the website link there as well to the GTC. So in terms of resources that are available. So the website is always being updated with new resources as well. So please also have a look at that. So with that, I'd like to again thank the panelists and thank the audience so much for your active participation. We apologise in terms of time that I didn't get to all the questions, or we didn't. They all get collected, so we'll make sure we review those, and anything outstanding we'll address. So thank you again, and have a good morning or good evening or good afternoon wherever you are in the world.